Would you like to kick us off?
Sure. Thank you guys for coming. I'm going to introduce our speakers. I also wanted to let you know there will be a survey at the end, which we would love for you to fill out. So please, if you could do that too. So welcome. We have two speakers today talking about trauma-informed care. The first is Dr. Lisa Carlin, who is a licensed clinical psychologist specializing in individuals who have experienced trauma. She co-owns the Trauma Resilience and Education Center of Washington, D.C., or TREC DC, which she founded with Doctors Didion and McIntyre, which has the mission to provide evidence-informed and culturally affirming therapy, training, and education to those in the DC area. And then our second speaker is Dr. Chloe Goldbach, who is a postdoctoral fellow at TREC DC. Sorry, my phone is okay. Postdoctoral fellow at TREC DC, who is getting her doctoral degree in counseling psychology from Southern Illinois University. Prior to joining TREC, she completed her training at university counseling centers at Southern Illinois University, Carbondale, and at the University of Maryland College Park, where she specialized in gender affirming care and working with LGBTQA plus young adults and individuals experiencing outpatient disordered eating concerns, as well as individuals experiencing difficulties with emotional expression and distress tolerance. So we're very lucky to have them here today to talk with us about trauma-informed care principles, and I will let them take it away.
Dr. White, thank you so much. It's so great to be here. I'm going to hopefully share slides. Can I get a thumbs up from folks if you can see that? All right, thanks, Keith. Okay. And let me go into slide view. So again, my name is Lisa Carlin. It's so nice to be here with all of you. And
I'm
Chloe
Chloe Goldbach. Also, thank you so much for having us.
And I know that we want to make this as interactive as possible using the chat function. So I'm going to do my best to monitor the chat. If I can figure out a way to get to that while I'm sharing. Actually, I'm not sure if I'm able to do that. So Chloe, you might need to monitor the chat if you don't mind.
Sure.
Okay, so I'll share and Chloe will monitor the chat, but we'll take turns on presenting, but would love to have your feedback in there. And so I'm just going to start out just inviting folks if you want to put your preferred name and pronouns in to rename your little square there if you'd like. And we will move forward.
Okay. Yeah, so just like a bit of information at the beginning as a part of like informed consent. Given that, of course, this is on trauma-informed care, some of the examples will, include some trauma material or trauma narratives. All of these examples are composites of, client work and not based on any one individual in order to, respect anonymity and confidentiality. Of course, respond to your own needs as indicated, and we are not going to force anyone to participate, but we encourage you to, opt in to join in any of their reflection exercises through the chat, like Lisa mentioned, but also understanding that for a variety of reasons, some of you may not choose to or may not be able to engage with some of these exercises. So the very brief overview of what we'll be talking about today. We'll be talking about the 6 principles of trauma-informed care, along with some example scenarios and discussion questions and how we can apply this based on the settings that you work in. We do understand that there are time limitations. We have about 40 minutes today, so there are some slides that we'll go over briefly. We'll also have some resources at the end of the presentation for you to take with you. And like Keith said, you all should have hopefully received all of the slides already for your reference after the presentation as well. Anything you would add, Lisa?
No, just I guess maybe I can segue into the next slide with this, but we certainly are aware that this is not the first time, probably not the 100th time that you've heard about trauma-informed care. And so we want to really recognize the wisdom in the room with us today. And we're going to just kind of briefly reiterate defining trauma-informed care here, and hope that we can give you some some ideas, some thoughts, some opportunities, since you are taking your time here out to join us today to think through how you're already providing this care in very trauma-informed ways, and things that you might want to build on or bring back to your teams depending on your setting. So, first, just like as a brief reminder about trauma-informed care. So this is a strategy that has been implemented for a long time, first coined by SAMHSA, talking about these 4 Rs are often what we hear about with trauma-informed care, right? So kind of realizing the widespread impact of trauma, even if we don't know the person in front of us, all of their history, we can know that unfortunately trauma is pretty widespread. And we all are impacted by it, whether personally or those in our family or around us or in our communities, right? So realizing that, recognizing signs and symptoms that of folks that we might come into contact with, responding using that knowledge, not just of those interactions that we have in the moment with folks, but also within our systems, how we can be responsive in our systems, as well as resisting re-traumatization whenever possible. Again, not just in those individual experiences and interactions we have, but within the systems that we're providing that care. And by the way, if at any time folks have comments that they want to share or questions, please put that in the chat. And Chloe, just stop me if I'm the one talking to let me know.
Sure.
So we want to focus mostly on kind of, well, what does that look like, right? We can have these principles. We're going to be going through some different lenses to look at trauma-informed care. But we want to understand, well, what does that mean in implementation? So, certainly I think folks here would probably all agree that it's important, right? And we're not going to spend a ton of time on that today, since again, you all are well versed in this, I imagine. But certainly, it does have a real impact, right? It can increase mental health conditions such as PTSD and others. We can miss some important signs of support. Certainly, impact of trauma, of course, interacts with a lot of different medical conditions as well as mental health. I like to point this out too. This last bullet on here is that, psychoeducation, when we're talking about trauma therapy, like psychotherapy, trauma education is the first part of any type of evidence-based or evidence-informed approach. And, I've yet to have someone that I'm working with, fail to say something like, oh, I didn't know that, or I didn't understand the impact of trauma, right? I'll say my soapbox about how we could be as a culture doing better around, myself included, being aware of all that can be impacted with trauma. But it's really important that we understand it for ourselves and others. Love to invite folks to start some participation in the chat.
Hey,
go ahead. Oh, sorry. Was there a question? Oh, okay. I would love to invite folks to share in the chat. Again, wanting to recognize that you're probably already, not probably, I'm sure you're already doing things that are trauma informed, and would love to get some examples of that in the chat, as well as some maybe questions that you might have coming into this presentation about, how that could be more accessible, or barriers that you find to implementing these strategies. That certainly could be, wanting some more examples of how to implement them, or just wanting to also recognize that there are a lot of varied and nuanced and complex situations that you all come across, and there may be some challenges to some of the strategies that we are going to be going over here today. So just want to invite folks to share anything in the chat that you're hoping to learn today, that struggles that you have, or things that you're doing well and maybe want to be doing more of. So I'll let you all think and share if you like around that. We're gonna take a perspective today around 6 trauma-informed core principles. So you can see them in those bubbles around. We're going to kind of take our way around the circle here with you all during their time together to see how we can apply these different principles in some different ways.
And one of the things shared in the chat was time limitations are a big
Yes.
challenge.
Fantastic. Yes.
Working in the ER, so usually meeting people for the very first time.
Yeah. Absolutely. So really want to, and we'll do our best to integrate some of what you're sharing in the chat. Thank you for putting that out there. We want to be practical and pragmatic right around this. This is not, we're not when we talk about trauma-informed principles, we're not saying like, okay, let's, take the next 45 minutes to have someone talk through their traumatic experiences, of course, but how can we be relating to people in ways that are trauma-informed, even in those brief encounters, which again, might be noticing what you're already doing and making space for more of that. So I'm gonna hand it over, I think, to Chloe to take a look at our first core principle.
Sure. Yeah, so our first core principle is really just understanding trauma and associated distress.
Oh, I think I was actually
Oh.
right.
Yep.
Did I hit it off to you too soon?
Maybe. I don't know.
Okay,
You can
okay,
go
sorry
ahead.
about that. Yes. Um, sorry, go ahead, Chloe.
Oh, yeah, I think I have the second principle. So,
Okay, got it. All right. Well,
Yeah.
then I'll keep talking. Sorry. So this again, I'll go through pretty quickly too, because we may know some of these already. We intentionally put some of these up here, and obviously there's more impacts of trauma as well. But we might have someone sitting in front of us. We might not know, of course, what's going on internally for them, but here are some ways that it might come out in social interactions as well as in physical, emotional, cognitive interactions. So want to just invite folks to share in the chat examples that you might see in your offices, in your settings, things that we missed here that come up a lot for you all as well. Again, how can we understand? Now, of course, if somebody is, sharing that they have disturbed sleep, does that always mean that that's because of trauma? No, but just understanding that that could be a factor. And one other thing we wanted to point out, again, this could be, and if you all want it to be, could be a whole other presentation, but we do want to just also appreciate that as doctors, as providers, that you all also are impacted, not just potentially in your own personal lives, but by engaging with folks that are coming in with experiences of trauma, psychological and at times physical trauma, right? And that we're impacted by that. And so we wanted to acknowledge that we are impacted and therefore may have a very human want to avoid the intense emotions that come up for us. Sometimes this can be a barrier to engaging in trauma-informed care. It might make it difficult for us to acknowledge what's going on. We might have some very normal urge to minimize or doubt people's experiences or other ways that we might avoid our own emotional reactions. And of course, sometimes that's necessary to get through the day. And it doesn't mean that there's no impact. And so, just really want to further underscore things that you may be doing to acknowledge that for yourselves or ways to come together at opportunities like these to give yourself a break, whether it's for learning purposes or coming together in community. Okay, now I'll turn it over to you, Chloe.
Okay. So, our next principle of trauma-informed care is cultural humility and responsiveness. So, we, in psychology and in other fields, there's been a push to move from this idea of multicultural competence to multicultural humility, to recognize that there's not like an end point in terms of like our understanding of our identities and the identities of others and how that impacts the care we provide, the experiences that people have. So it's really having this like ongoing learning and appreciation for like our own identities and how that connects to, our standings of any social privileges or social oppression or marginalization. And then likewise for all the people that we're working with. And, connecting to all the different identities that somebody may hold, including the ones up here. Didn't put it on here, but an acronym that can be helpful is the addressing framework, if anybody is familiar with that. Thinking of age, disability, religion, ethnicity, socioeconomic status, sexual orientation, nationality, and gender. So that can be a helpful acronym to like help us, make sure we're attuning to all these different parts of identity and not just like the aspects that may be like visible as well. Because it can be easy to miss like invisible disabilities or, trauma, for example, might not be immediately apparent if we're not knowing how to, ask particular questions to assess for that. So it's really just thinking about how does all this impact the client's experience, both from strengths and stressors perspectives. So we have our first sort of reflection case example. So I'll read over this, and we have a couple questions here. I'll encourage you all to, share in the chat, any responses that you may have to these questions or just any broader reflections to this example. Knowing that this is like just a snapshot and likely all the details that you would have in person would be more comprehensive. But we have Kendra here, who's a 7-year-old Black girl who presents to a pediatric clinic with her mother for a comprehensive exam. And when you introduce yourself to her and her mother, you notice that she appears nervous, shy, does not make eye contact. Her mother reports that she has a history of shyness, struggles with sensory issues, and had a distressing experience with another provider about a year ago. So, based off of the information here, what are some of the identity and cultural variables that would be important for us to take into account in order to approach our care from a trauma-informed and cultural humility lens? Knowing that this is a snapshot, what additional information would we want to know to be able to provide like comprehensive holistic care that is trauma-informed? And, safety is a big piece that we'll be talking about throughout this presentation. So given the information we have, given any information we'd also want to know, how might we create a safe environment for Kendra? So I'll give, y'all a couple minutes to, read over this and share, if you feel comfortable, and answer to one or more of these questions. How you might approach this if Kendra came to you for care.
One thing I'm thinking of while folks are writing Chloe's, and maybe this, I also want to be holding what folks were saying or sharing earlier around meeting folks for the first time, having limited time, right? My mind maybe as a psychologist goes to like wondering how this presentation changes as we sit in the room, as I might engage, you know, as I might engage with Kendra, aware of my own identities as a white woman in the room too. Yeah, looks like we're getting some responses. That's saying to get more information about the distressing experience. Yeah, that was on my head too when I first read this vignette. Maybe discussing that with the mother outside of Kendra's earshot to start. What was the nature of that interaction? Was it medical care, vaccines? Yeah, and another opinion that even if we don't need the details of the past, try to re-traumatize. What can we do? Ask what we can do to make them feel more comfortable with the visit, what we can avoid. I love that. To both of those just talk about like getting more information and how we might do that. Paying attention to developmental milestones, right? Kendra's developmental age. Yes, it's also a great one.
Sure.
Let me just, making sure to explain what we're doing. Yeah.
Yep,
Great.
creating
Yeah,
clear
Chloe,
expectations. Yeah.
Yeah. Yeah. Anything you want to add there, Chloe?
I mean, I think similar to what you said, being mindful of like how my identities intersect with Kendra's identities, her mother's identities. Thinking about the sensory experiences, wanting to know, is there any degree of neurodivergence present that would need to be important to take into account? How we might create just a safe environment for her knowing this information. And yeah, again, knowing like what happened last year. And I like the idea of like maybe talking about it with her mother when Kendra's not present, to avoid any like traumatic stress reactions as much as we can.
Right. Yeah, and that's what I was seeing in the chat, Ariel putting there, spending an extra few minutes chatting. That's kind of where my mind went to, recognizing we don't always have that luxury, right? But also recognizing like when can that be built, or building rapport in some ways, right? Recognizing power dynamics in the room, and how can that be at least acknowledged in how we're interacting with folks. Great.
Yes, so our next principle, as a direct extension of this, is, safety and stability. And, one of the ways that we might approach this is through an informed consent or assent process. I think some of you have already tapped on pieces of that in the chat in terms of like making very clear expectations of what, the health exam in that example will look like for Kendra. So that way people can have an informed consent to like what this process of healthcare is going to look like with you. So just as like a few questions for the chat, um, when we think about informed consent or assent, what are things that you're typically looking for? What challenges may come up? And are there any limitations to confidentiality or other factors that you're taking into account that may affect, the ability to create like that safe and kind of grounding environment that you are trying to create for your patients?
Yeah, it's a great point. And it's putting that chat depends on the age of the child. Um, I'm clearly not a pediatrician. I am a parent, and I'm thinking through kind of all the ranges of experiences that we've had, and the different, again, whether it's time limitation, urgency limitations, my child's age, or level of assent to what's happening. I imagine comes up quite a bit. Um, yeah, and here's an important point, being mandated reporters, right? How that intersects with informed consent, right? That's, part of what, we might ideally share or remind folks about, but folks coming in, if we hear about abuse, if we're concerned about abuse, that might be taking place, certainly that's a place where confidentiality not just can be broken, but is legally mandated to be broken, and in most cases. So, there's certainly those limitations. This is probably outside of the scope in this moment, but just wanting to acknowledge, right, the ways that we could still employ some trauma-informed principles, even when we are engaging in things that need to be outside of someone's consent, for example, and those reporting, right, to, depending on the nature of the situation, of course, what can be shared with whom, in what way, is there any choice that we can provide someone, even if they don't ultimately have the choice about reporting. And if Chloe, you wanted to add anything else in there?
I don't think so. I think we can jump to the next
Move on?
slide.
Okay.
So, again, this is kind of just an extension of these pieces. But, of course, when we're building a safe environment, building that rapport, building that sense of trust is critical. And, sometimes we'll have to give patients, families, caregivers, difficult feedback that might be necessary in the provision of effective care. So, these kind of overlap here, but what might be some challenges you've encountered in building trust, with who you work with, and how might you integrate that with giving difficult but necessary feedback to give them the best care possible? Like, how do we kind of maintain that balance?
one thing it makes me think of, Chloe, is just like and I imagine this is something that all of you are doing is, that need to be direct, that need to, um, to, provide the information needed with, compassion while also, um, you know, allowing the impact that might happen with depending on the feedback that we give, allowing space or acknowledgement of folks' emotions around it. Yes, time limitations absolutely are a challenge here too, especially when it comes to building trust and giving feedback. And challenges that come up when using interpreters. Right. I'm looking at cannot control the whole medical facility. I
Yeah.
resonate with that, having worked in medical settings. Um, absolutely. Absolutely. I I'm curious if folks, what folks might have to say, or you, Chloe, too, around the acknowledgement of what's in control, like the transparency piece, when possible, of what can be controlled here, what can't be controlled, the acknowledgement. I think also I've seen can go a long way by medical providers of acknowledging, like, or even someone feeling heard and believed for their experiences. So I know in the previous slide, folks had talked about like understanding more about previous, harm or trauma, like maybe in a medical setting, lack of control in different ways. I just want to plug in for what you all are, I'm sure, doing in terms of creating trust by believing folks with what they say and acknowledging emotions that might be shared about it, or even wondering like, I imagine that was really difficult. I wish there was more I could do to control that. Here's what I can do. And yes, I'm seeing the chat around mention of CPS involvement, putting on the defense. Absolutely. Yeah.
Giving
So
choice
again,
when you can. Yeah,
yeah,
that's very important.
absolutely. Great. God, these are great suggestions. Oh, I see yeah, unfortunately, looks like an example of not being believed being put in the chat here. Yeah. Right. Not, I certainly, as I'm saying that, don't want to, want to acknowledge that not everyone, in fact, all of us to some degree are not going to be 100% accurate reporters all of the time. And trauma can impact that, right? Someone was sharing earlier in the chat around, trauma can impact our memory, how we discuss things that have happened, how we remember, how we can, kind of piecemeal together histories that can make it difficult for you to do your jobs in a limited time as well. But to kind of give folks the benefit of the doubt of doing the best that they can, realizing, that most folks in fact are doing that, can again kind of go a long way into building trust even in those short interactions.
Yeah, so kind of just going off of that, we, pulled this model that, is sometimes used in pediatric care for creating a trauma-informed approach. This idea of like attuning to DEF after the ABCs, of kind of making sure that we're addressing both physical health and emotional well-being, and tapping into a lot of these pieces that we're already talking about, of like assessing like, what is this distress, where is this coming from, what are like any of the fears or worries, like how do we help create that safe environment centered around informed consent. Really asking like, what does this person need right now, and are there any barriers for them to be able to get the support that they need, either with, in that appointment or outside of, your interaction with them? If there's any way you can bring in the family to, have them provide the support that they may not even realize that they're either not providing or not knowing to provide. And of course, this is a system, so it's like really seeing like how is the family's distress impacting the child's distress, and kind of vice versa. Really addressing like the needs from a holistic perspective. And then, yeah, we can go ahead in
No,
the
sorry,
interest of time.
yes, yes.
Yeah, so we have another example here, and some of the responses you gave may be similar in this case in terms of how we're building safety and trust for, in this case, Emily, who's a 9-year-old biracial girl. And she recently had an accident while riding her bike when she was in the care of her mother and her mother's significant other. Um, after being transported to pediatric care, she seemed quite sensitive and bothered by loud voices and noises. We notice as her condition starts to improve, she began to act out by refusing to participate in her care. Some staff were describing her as difficult. Different reactions from her parents, her mother asking the staff to not push or force her to participate, but father expressing more anger towards what had happened, increasing some tension for everyone involved. Emily observes these interactions, and she's worried that her parents were fighting, that her parents' fighting was her fault because she had the bicycle accident. Knowing this information, how, again, might we build trust and safety for Emily? What additional information may we want to know about Emily's history to better understand and, of course, better address this distress she's experiencing? And what are ways that we can, bring in and engage, Emily's parents and caregivers in a trauma-informed manner? So I'll give y'all a couple minutes to, reflect on this and share any thoughts that you have in the chat.
While folks are doing that, I'll just kind of share some of my reactions. Like or one of my first polls would be to acknowledge all the emotions that might be going on here for this family and for the girl, and to again kind of going in, maybe being mindful of our own tone and approach, and staying calm ourselves, and um recognizing the different roles that folks are playing here, and again acknowledging just different people's reactions to emotion, right? Not as good, bad, right, or wrong, but also recognizing like how we can work together to get done what needs to get done, right? Aware that things like kind of coming in with raised voice or trying to exert lots of control or aligning with one parent over the other might just exacerbate things as well. So absolutely. So seeing the chat, kind of normalizing the reaction, centering that, yes, how we
Yep.
could be on the
The
same
shared
team.
goal.
Exactly. Yes. Yeah. Absolutely. Yeah, a lot of this like validation, normalization, again, can go a long way. I
And
really
taking
like that
steps
too.
to avoid re-traumatizing.
Yeah.
Yeah.
Yeah, I think that's a really helpful one. I won't go into the whole case example, but I actually recently had a client that had a very challenging experience in a medical setting that was related to kind of her trauma history wasn't completely unrelated to the appointment and that she was attending. However, the details of the trauma experience were not pertinent, and being asked, my apologies, being asked about very specific details about her past trauma experience was absolutely re-traumatizing and triggering. And so again, that idea that sometimes having details could be helpful, and not always can be re-triggering. And even as trauma therapists, we walk that line. And I often tell folks, trauma processing or even being trauma informed doesn't mean talking about details of what's happened all of the time or thinking about all of the time, right? There are times to be focusing on different aspects and to be mindful of the impact of those memories.
I feel like those points are especially important with like the time constraints and considerations
Exactly.
that we're talking about, just in terms of like, if we have a very limited time, want to be very mindful about like what are we bringing into the room and do we have time to adequately care for the distress that's maybe coming up.
It's a great point. Yeah. Okay. All right. Let's go back to me.
Yes.
Excellent. Okay, so collaboration and empowerment. Some of these things are going to be overlapping with what we shared before. Again, our using of these 6 principles isn't to put everything neatly into boxes, but just to have different pieces of the lens, like we're moving a prism around as we're looking at some of these core principles. So I will be quick about this, but I think it can be helpful sometimes. We won't ask anyone to share any details about your experience, but to think about a time when we ourselves personally didn't feel in control. Here, I'm not asking folks to think about a traumatic experience, or certainly, again, only engage in this reflection if you would like to. But I'll share an experience that comes up for me with a question like this. I was recently had a friend who was actually engaging or getting surgery, needed a medical procedure. She lives out of state. I was trying to get there to be of support for her, and didn't have access to a car, needed to rent a car to be able to do that. Made the reservation, went there, didn't have the reservation, stereotypically. And I was feeling, as you can imagine, just, so distressed, right? Trying to be there for my friend, having this situation not go well. I probably did not have a tone or reaction that I would be necessarily 100% proud of. And it was so important, right, that the person in front of me, this is not in a clinical setting, by the way, I'm at, I can't even remember, probably enterprise, right? That the woman I was talking to responded to me in a very calm voice, let me know what she was able to do, let me know what she wasn't able to do. So like, I don't have a car right now. It is very possible I will be able to get a car within the next hour or two. Would you like to have a seat here? Would you like to go home? Like, she was giving options. She took what I had said seriously, certainly normalized that. And it was super helpful to kind of help me kind of snap back into like, right, like, of course, this isn't this individual's fault I'm talking to, but to kind of be aware of like, wow, like I was in distress. I was feeling out of control. I needed to, in my mind, I like needed to be there yesterday, right? And again, these are brief encounters sometimes with strangers, right? And not always even in a clinical setting, where, how we respond can really go a long way. Not it was just not to say that we need to tolerate or say it's okay if people do treat others disrespectfully or use hateful or hurtful language, right? Obviously, like not condoning that, but just recognizing like in that moment of feeling so out of control, it was just so helpful to have someone respond again in a calm way with what the options were, and and take me seriously, or to acknowledge the emotions that I was having. So, kind of thinking about like what are those elements of, how do we like to be responded to? What are some qualities that are important to us? How do we want to embody that to others, particularly when things are out of our control? Right. So, again, these are kind of reiterating maybe similar points, but, trauma is, sometimes defined as a loss of power and control, right? They're inherent in these experiences, right? And so it can be really critical to, like someone was saying, I think in the chat, is like, okay, what are the choices that we have? And particularly when we think about children, right? Of any age, right? And how that comes out in different developmental stages, right? What younger children respond to having a lack of control versus elementary school, middle, high school age children, right? Adolescents, right? That it's normal for all of us, and thinking about the ways in which, children have less control in so many different ways. So finding ways to build agency, finding ways to have those, which sticker do you want? Which band-aid do you want? Like where can be some ideas for some control, which of course can be easier said than done in some of your settings for sure. But again, kind of having that mindset of like, where can there be control? Where can I offer choice? And to the child, but also of course to the family. Similarly, building collaboration and empowering in that way. Again, thinking about personal considerations, again, kind of staying mindful of the power dynamics in the room, as well as communication styles. I really like someone in the chat had said, like, asking ahead of time, like, what are your needs, or maybe what are your expectations, right? Having things be transparent, validating concerns, validating what you can't do, validating perhaps what there isn't time for, right? Like, you're not going to be able to magic up more time or more options. And we can also acknowledge that and empower folks to have to understand what their choices are. Or perhaps if they have more time to make a choice, if that's a possibility. I realize it isn't always, but if there is more time, and how they can take that time and then communicate back what their choices are, for example, about medical options or treatment plans.
Back to me.
Absolutely.
Yeah, our next core principle is compassion and dependability. So, this is probably no surprises in terms of what we're talking about here, but, compassion, we're, talking about kind of approaching with a caring, understanding, and empathy, recognizing struggles, suffering, experiences that people are having, and approaching it in a way that is not only gentle and kind, but is allowing the person to feel heard, understood, and validated. And I think if we jump to the next slide, I think, a lot of times as, healthcare providers, caregivers in various capacities, we can be a lot better at providing compassion for others than for ourselves. So really like honing in on this idea of like, how do we take space and time for self-compassion, within the context of our work, of course, but even more broadly. And, there's kind of like three components here of really being able to recognize from a mindfulness perspective of like, when are we stressed, but also resisting that urge to beat ourselves up or be overly judgmental, kind of just normalizing that distress that we're experiencing. And with that, kind of remembering that like there might be times when we have to take a step back, or, recognizing that we are not existing alone, existing in a vacuum. Like, who are the people we can reach out to for practical support, logistical support, emotional support, recognizing that experiencing difficulties and stressors are a normal part of life. And really just to kind of taking some of that kindness and compassion that we will regularly provide for the people we work with, and making sure we also direct some of that towards ourselves. There's this, one way we can think about compassion is thinking of like different ways that we can kind of direct this compassion. We might think in maybe the typical approach of compassion is maybe from like a self-care perspective, or a tender self-compassion, accepting ourselves, using a sense of calmness and soothing to, help reduce our distress. But another element that we may overlook could be a fierce self-compassion, that we may not even think of this in the context of compassion. But this is a form of like kind of taking action, kind of an external approach to self-compassion as opposed to a more inward directed approach. So really, being able to identify and say yes to our needs, being able to identify when we need to set boundaries, being able to identify when we need to seek support and guidance from others, and being able to identify when it's important to, advocate for ourselves and those that we're around, acknowledging the systems that we're in and how that's impacted us personally and professionally.
Cool. I think we're about almost at time, but maybe we
Yeah.
could just at least acknowledge this is a potential fierce compassion response.
Yeah. You read my mind. I was
Okay.
gonna say like we could just, reference this and kind of move on. But as like an example that you'll have, working with a gender diverse patient, working with a 10-year-old trans girl, we recognize like, Ashley here uses she, her pronouns, but her parent refers to her with he, him pronouns. Thinking of like, how might we tap into this fierce, compassionate response of, kind of this advocacy approach, setting boundaries, standing up for what feels important, and how might we deal with any challenges we might encounter, knowing that, we're working with a trans girl who's being misgendered by their parent, it's a nuanced situation that probably requires a lot of care, but a lot of like compassionate approach as well.
So I know we're about out of time, but I'll just do like a quick note on resiliency. I know that that can be speaking of like a nuanced and complex word, right? Of course, we would wish that, the kids and families that we work with don't need to be so resilient because of the trauma they've experienced. I do want to just kind of do this plug for resiliency researcher George Bonanno talks about resiliency not being a set of traits, but even though they thought at first that they would find sets of traits for resiliency, but actually it's about how we flexibly use the resources and strategies available to us depending on the needs of the situation. So it's really helping to learn that behavioral flexibility that is the important point of resiliency, and that can be a learned skill to be able to increase that flexibility that hopefully all of us as providers can be working and supporting folks in. So before we end, I do want to give a plug to kind of next steps if you're interested. There's a video here that gives an example of a medical practice like implementing principles to the population that it's serving, in this case, a Native population. But that was a helpful way of like, okay, how do we put some of this into practice in our systems? So if folks, I do not want to start that. If folks, want to, look at that later, perhaps reflect and plan within your clinics or within yourself or systems, how to put some of these things into practice. It's going to recognize that that can be difficult to do, but I really appreciate the ideas that folks shared. Hopefully having some time to think through it with these different lenses with us today is helpful to keep things top of mind and use our own creative problem solving and resilient approach to helping us to do more of what is aligned and to help limit where we do have control, some of those re-traumatizing aspects. So thank you so much. We're going to stick on here for any questions that folks might have, and you have these resource pages, as well as ways to contact us in the future. All right, so please feel free to add any questions that you might have into the chat. And if folks are dropping off, just want to wish you a good rest of your day, and thank you for joining.